and welcome to another episode of Samaj Ke Rato. A lot of students ask me questions on steroids. Okay, कि ma'am, there is a question in NEET or there's a question in INI wherein the patient is taking steroids. So what should be the protocol before extraction and how should we proceed? What dose of steroids should be given? Should it be doubled? Should it be the same dose? Should it be skipped? So there's a lot of controversy also. There is a lot of difference in opinions also, but there is a lot of common consensus also on steroid. So today in this episode of Samaj Ke Rato, we are going to understand everything about the steroid story and the relation of steroids to surgery. Okay, so first starting with the basics. Okay, what are steroids, where they are produced? Now we all know that this bean shaped organ in the flank region of our body is the kidney or the renal gland. Okay, just above the renal gland is the adrenal gland. Okay, a gland which is just above the kidneys is the adrenal gland. Now this adrenal gland is very important for survival. Okay, for conditions of stress. Okay, now if I have to draw this triangular shaped adrenal gland, we know that it is composed of two parts. There is a cortex, which is the outer part, and the middle part is the medulla. Okay, lot of hormones are produced by the adrenal cortex. So cortex makes up the glucocorticoids, mainly cortisol. Okay, the mineralocorticoids, mainly aldosterone. Basic physiology we've all learnt in our first year's physiology. And gonadocorticoids, which is the estrogen, testosterone and all of that. Okay, estrogen, progesterone, testosterone and all of that. Now adrenal medulla produces your catecholamines like adrenaline, noradrenaline, etc. Alright. Now, what is important in our context is these two hormones, glucocorticoids and mineralocorticoids. They are very important in cases of stress. Okay, now what is stress? What do I understand by stress? Okay, stress, in normal terms, when we say stress, we mean psychological stress or tension. Okay, so that is the common understanding. Stress matlab bahut tension hai. Okay, yes, that is a little bit of stress which generates some some imbalances in the body. But the major physical stresses which happen on the body are like illness, fever, infection and surgery. Okay, these are the major contributors of stress. Infections, illness, pain, fever. So what happens is, these are certain situations where the demand of the body increases. The demand increases. Demand for what? Demand of extra energy. You need extra glucose. You need extra blood pressure so that the stress can be tackled. Okay. Now, our body is really magical. It is able to balance out things. Now, when I say that my adrenal glands are going to produce adrenal cortex hormones, why will it produce? Until and unless the brain is going to tell the adrenal cortex that please do it. So there are two little organs here within the brain, which is the hypothalamus and the pituitary. Together, these three glands or three organs of the body, hypothalamus, pituitary and adrenal gland, make up an axis called the HPA axis. Okay, which works whenever there is a stressor. What stress? What is stress? I just told you. whether it is a psychological stress, which is very mild, illness like fever, infection, a pain due to trauma, or a surgery. Any of these things can be a stressor. So whenever there is a stress, okay, the body signals the hypothalamus, okay, you should secrete you should give a signal to pituitary. Pituitary will give a signal to adrenal gland, create a releasing hormone. And the adrenal gland will finally secrete cortisol, okay, which is a major contributor to reduction of stress. Okay, so the cortisol, when a good amount of cortisol comes to the bloodstream, it takes care of all the stress things. Okay, hypoglycemia, hypotension, bradycardia, everything that happens due to stress, the cortisol takes care of it. Okay, and cortisol gives a negative feedback to the hypothalamus that now I am enough, there is enough cortisol, stop producing more cortisol. So this axis is the HPA axis, which works normally in people like you and me. Okay, if this axis is not there, if the cortisol production is not there, okay, if cortisol is not produced in stress, what will be the effect? The effect will be everything goes down. There is profuse sweating, there is hypothermia, there is hypotension, there is hypoglycemia, okay, dyspnea, hyponatremia, a lot of things will happen, but broadly the systems in the body will go down. Okay, and as soon as cortisol is produced by the adrenal gland, everything starts getting secreted. There is increased glucose availability in the blood, so hypoglycemia is corrected. There is more sodium retention, so if sodium is retained, water is also retained in the kidneys, so blood pressure comes up. Increased potassium excretion from the cellular metabolism. But like we say, everything is a double-edged sword, and especially steroids are double-edged sword. दो धारी तलवार है, कुछ फायदे हैं तो कुछ नुकसान भी हैं. There are some side effects like increased suppression of the immune system. This is a very, very important effect of the steroids, whether it is endogenous or whether it is exogenous. This is a very important effect of steroids. Okay, so what cortisol will do? It will do two things. Cortisol will help fight stress. What stress? Stress of illness, stress of fever, infection, inflammation, surgery, any kind of stress. But it will decrease the immune response. It will decrease the immunity in a person. Okay, so this is what happens normally in the normal situation. Now our body is also very smart. Okay, it follows something called as a circadian rhythm. What is circadian rhythm? Circadian rhythm is like a day-night cycle. So what body does is, in the morning only, it will secrete a high dose of steroid. Okay, at 8 a.m. के सुबह सुबह भगवान will give you so much steroid कि पूरे दिन तुमको जो भी tension है, that will be taken care of. Alright, in the morning, the body secretes at 8 a.m. You can see it is the maximum secretion. And again at 8 a.m. in the morning, it is maximum. It dips. As the day passes by, the secretion of cortisol goes down. And again, as like from 1 a.m. to 2 a.m. in the night, again the cortisol secretion starts increasing. Okay, so in the morning at around 4, 5, 6, 7, 8 a.m., the highest cortisol secretion is in the morning, because God also wants that all your day's stresses should be taken care of by enough cortisol in your plasma, so that the day's stress, tension, little bit of here and there is taken care of. All right, around 20 to 30 micrograms per day cortisol is secreted according to this cycle. All right, in normal people. If you have seen some patients who are taking exogenous steroids, you must have seen that, doctors are prescribing, like for example, tablet Vizolon, 5 mg, ABF. So doctors write this word ABF, like we write, right? OD, BD, TDS, QID, HS means before night. ABF. What is ABF? After breakfast. Why do doctors normally recommend taking steroids after breakfast? Because normally we have breakfast at around 8 or 9 a.m. So physiologically also, they want to supplement the cortisol cycle. So they give steroids most of the times. They start giving steroids with a morning dose, with a dose after breakfast, so that the physiological rhythm of highest level of steroids in the body, which is at 8 a.m. in the morning, is maintained. Okay, so normally whenever we prescribe steroids, usually we start with a morning dose. Okay, now with this we come to, then what is the problem? Okay, when does adrenal insufficiency happen? Okay, so adrenal insufficiency, that means deficiency of cortisol or deficiency of hormones secreted by the adrenal cortex. Okay, adrenal insufficiency can be divided into primary adrenal insufficiency, or known as primary AI, and secondary adrenal insufficiency, or secondary AI. Okay, this is very, very important. Please understand this very nicely. Whenever we say a primary disease, that means the cause of the disease is the adrenal gland. That means there is some atrophy, some tumor, some problem, some disease within the adrenal gland, because of which it is not able to secrete the hormones. Okay, so cortisol is also reduced, aldosterone is also reduced. Okay, gonadotropins or gonadocorticoids are also reduced. Okay, gonadotropins nahi, steroids, gonadocorticoids. Depending on how much gland is involved and what is the problem, all the cortical hormones are reduced. And this is a very, very dreadful situation. Okay, in this situation, a little bit of stressor to the patient can be life-threatening. He is always supposed to be on exogenous steroids. Any stressor has to be identified and more steroids need to be given so that the stress can be tackled by the patient. It is very, very rare. It is very, very rare for a patient of primary adrenal insufficiency to come to your clinic for a tooth extraction or an RCT or anything, and you have to give and you have to maintain that patient. Whenever this happens, you have to actually consult an endocrinologist, do it in congruation, probably in a hospital setup, so that there is no crisis. Okay, more common is the secondary adrenal insufficiency, which is very, very common, much more common as compared to the primary AI. Primary AI is basically the Addison's disease. Okay, it is Addison's disease. Now secondary AI is secondary to some other cause. किसी और कारण से adrenal पे effect पड़ रहा है and secondary to some other reason, it is causing an adrenal insufficiency, like other organ disease, like we have seen a hypothalamus disease or a pituitary disease. We know that it is an HPA axis, right? So whenever there is a demand, first the hypothalamus has to tell the pituitary to secrete the releasing hormone. Then pituitary will secrete and order the adrenal gland. So if there is a disease of hypothalamus or pituitary, like a pituitary adenoma or a hypothalamus tumor or some problem in one of these glands, actually adrenal में कोई problem नहीं है. Primarily adrenal gland is okay. But secondary to the other organ diseases, the adrenal gland has reduced its function of secreting hormones. Okay, so other organ disease, or it can be due to much more common exogenous steroids. What is exogenous steroids? Any steroids that the patient is taking as a pill, as a tablet outside from the body. It is not secreted in the body, it is taken from outside. Why will a patient take exogenous steroids? Most commonly for diseases like the autoimmune diseases, autoimmune conditions like SLE or RA, whenever there is a connective tissue disorder or a rheumatological disorder. These are autoimmune conditions when the body's immunity is abnormally high. So like we have read that it reduces the immunity also. So for this purpose, we give steroids so that the autoimmune problems are under control. Okay. Or in conditions like transplants, graft transplants, whenever there's a patient of cardiac transplant or a renal transplant or a liver transplant, also in such cases, we don't want any reaction against the transplanted organ. So these are the conditions when the patient is prescribed exogenous steroids. Okay, there can be some ophthalmic conditions, some autoimmune conditions on the eye, or some autoimmune disease. So for these reasons, the patients are given exogenous steroids. Which steroid is the patient given? Glucocorticoid, cortisol or related drug. Okay, the patient is usually given cortisol. Okay, now we know that adrenal gland does not produce only cortisol. Adrenal gland also produces mineralocorticoids like aldosterone. Okay, so as compared to a primary adrenal insufficiency, wherein all the steroid hormones secreted by the cortisol are down, a secondary adrenal insufficiency, mainly an exogenous steroids, does not reduce all the hormones. It will reduce only the secretion of cortisol. The other hormones, mineralocorticoids, gonadocorticoids, are normally secreted because only one hormone, HPA axis, is suppressed. Okay, so if I talk about the severity of problem, the severity of problem is much more in primary AI as compared to a secondary AI where the severity is very, very mild. Why? Because even if cortisol is, HPA axis mein cortisol is suppressed, first of all, the patient is already taking exogenous cortisol. So his baseline level is there. Plus, even if there is a stressful situation like a surgery or an infection, the other other cortical hormones are still being produced. The mineralocorticoids are still being produced. So ऐसा नहीं कि इतनी severe crisis होगी like primary AI. So the crisis will be much, much, much less mild. All right. Now we will talk in detail about exogenous steroids. When is exogenous steroids a problem? Okay. If the exogenous steroids are given in small dose, it is not much of a problem. See, 20 to 30 microgram or even 35 microgram of cortisol is produced normally in our body. So if you are giving a patient around 30-35 mg cortisol daily, it is a normal dose. Why will that small dose affect him much? All right. But if you are giving a very high dose to the patient, yes, it could be a problem. Plus, I will also be worried about the dividing of dose. Like we saw, according to the circadian rhythm, if you are giving the steroid only in the morning, ABF, after breakfast, usually it is not going to create a problem because normally also our body secretes it in the morning maximum. But if the disease of the patient is such, the autoimmune disease is such that you have to give steroids 2 times in a day or 3 times in a day. Okay, if it is a BD dosing or a TDS dosing because of some very, very severe autoimmune condition, then yes, it can be a problem because the body is not used to having a very high dose of steroid in the evening. The body is not used to it. So a high dose steroid and a divided dose of steroid is a problem. Alright, these are the two problems where I will be worried whether I should supplement or whether I should not supplement. So ideally, when a question is asked to you, it should be very, very specific that what is the dose of steroid, which steroid is being taken, what is the frequency of giving that drug, and based on that, ideally, you have to calculate whether you should supplement the steroid or you should not supplement. Still, I will tell you how to solve the questions also. Now we come to a very, very important thing, which is a steroid conversion chart. Now our body secretes cortisol. Okay. which is like around 25. When we supplement, we can give the patient cortisone. 25 milligram of cortisone is ideal, which is secreted by the body, which is average. Okay, suppose you think, no, I want to give hydrocortisone. Why? Because it has a half life of 8.8 to 12 hours, and it is mineralocorticoid efficiency is also good. So depending on the indication, if the rheumatologist says, "ये नहीं, मुझे तो hydrocort देना है," so for an equivalent of 25 milligram cortisone, he has to prescribe 20 milligram of hydrocortisone. If the doctor feels, no, hydrocort se kaam nahi chalega, I have to give him Vizolon, I have to give him methylprednisolone. So for an equivalent of 25 mg cortisone, he has to give only 4 mg of methylprednisolone. Why? Because the potency of the drug is very, very high. As compared to a 0.8 potency of cortisone, a methylprednisolone potency is 5, which is like more than 5 times. Okay, so whenever you are prescribing or whenever a patient is already taking, you have to know which glucocorticoid that patient is taking and what is the equivalent to cortisone, which is a baseline. So cortisone is a baseline. You always start with cortisone, which is a baseline. Okay, so whether he is taking prednisolone of 5 mg, okay, that is normal. Whether he is taking prednisolone of 5 mg, okay, that is also normal. But if he is taking methylprednisolone 20 mg, that means it is 5 times of the normal dose. So he is taking 5 times more steroids. And if he is taking that 20 mg in divided doses of 10 morning and 10 evening, it is a big problem. Alright, so this conversion chart, at least this part, you have to know. If he is taking tablets of dexamethasone because of some very, very acute autoimmune condition, if he is taking 1 mg dexa in the morning and 1 mg dexa in the evening, he is actually taking a 3 times dose of the normal steroid level. Okay, and divided into 2 parts. So then that can be a problem. Okay, so this is the steroid equivalence chart. Okay, how much cortisone is equivalent to hydrocortisone, methylprednisolone. So you have to know this chart. At least this part you have to know. All right. Another thing which helps you decide how how to decide whether steroids to be given or not is the type of stressor or the type of stress. Okay, what is the type of stress that is going to happen to the patient? Okay, like I said, it can be infection, it can be some pain or trauma, or it can be surgery. Okay, you can relate everything to surgery. If it is a mild infection, moderate infection, or severe infection. Like similarly, if it's a mild surgery, moderate surgery, or severe surgery. Usually the questions which are asked to us are based on surgery. Whether the patient is going to surgery under GA or whether the patient is undergoing only a tooth extraction, which is also a mobile tooth. Okay, so mostly the questions that come in exam are based on the type of surgery. Now the surgery can also be divided into mild, moderate surgery under LA, okay, or major surgery under GA. Right? These are the 2 classifications of surgery. Mild, moderate surgery, maybe some small pathology, extraction, some normal procedure. Okay? The current recommendation says that if the patient is on a steroid therapy, a low dose steroid therapy, for a mild to moderate surgery, no supplementation is required. But if the surgery is major, okay, yes, you have to supplement. Why? Because in normal people also, like you and me, we are not taking any steroids. But even if we go under a surgery under GA, even we will need steroids because the stress is too much. Now the stress is beyond the capacity of the body steroids to handle. Okay, if I'm undergoing a surgery under GA, it is a big stress. Plus, there are some effects of GA. What does GA do? Normally, when we give GA to a patient, the effects of GA is that GA drugs also decrease cortisol production. Sometimes we give barbiturates to the patient. Barbiturates also decrease cortisol production. Okay. Then pain. Pain is much, much more in a major surgery. All right. Pain is so much more that the body production of cortisol is not adequate enough to take care of that much pain. Okay. So these are certain factors which happen in GA. So whenever a patient is undergoing a surgery under GA, even normal person needs extra steroids. Even a normal person needs extra steroids. Okay, so whenever you're going for surgery, the anesthetist will give you a pre-operative hydrocort, an intraoperative hydrocort, a post-operative, say, Dexa, something like that, dexamethasone, so that generally the patient is comfortable. So obviously, when a normal patient needs steroids under GA, a patient with secondary adrenal insufficiency will definitely need steroids under GA. Okay, so based on all these facts, there are certain protocols. The protocols are divided between universities, that okay, AIMS says I am going to follow this protocol, Mayo says I am going to follow this protocol, or the protocol is divided based on the type of surgery. So cardiac surgeries, this is the protocol. Dental surgeries, this is the protocol. So the protocols are divided. I am going to tell you the basics so that you are able to answer the questions. This is the basic protocol that we use in dentistry. Okay. When you are doing routine dentistry, what is routine dentistry? Scaling, polishing, root canal treatment, fillings, small procedures, primary teeth, something like that. Even for a primary adrenal insufficiency, you need no extra steroids. For secondary adrenal insufficiency, that is exogenous steroids, definitely you don't need any steroids. Okay. Secondary AI, just to remind you again, this is the patient who is taking exogenous steroids. Okay. For minor surgeries, now what are minor surgeries? Simple tooth extraction, primary teeth extractions, frenectomy, mucocele. Again, for a patient of secondary AI, only the daily therapeutic dose is enough. You don't need any supplementation of steroid. For moderate surgeries also, it is enough. For major surgeries also, the recommendation says that it is enough. Do only what you have to do for a normal patient. The original dose should not be increased. Okay? For a patient of secondary AI, the normal daily dose should be the same. Rest, treat the patient as per the type of surgery. So, what is this asterisk saying? The guidelines are based on patient's AI status. However, the requirement could increase if the patient health is poor, fever, fear, anxiety, infection, fever, cirrhosis, major surgery, general anesthesia. Okay, in these conditions, even a normal person will need exogenous steroids or extra steroids in surgery. Okay, so the original dose, the original daily dose of the patient needs no modification, for any procedure in a secondary AI patient. The same is confirmed with the Miller article, which is a landmark article that we read, the Little and Follis book that we read, which is there, and it says that only two are the concerns in a patient with AI. Okay, in patient with secondary AI, we have only two concerns. First concern is the HPA axis suppression, which is minimal, which doesn't happen on a patient who is only on a glucocorticoid replacement. Okay. Second is decrease in immunity. So you have to give some little bit of more antibiotics, a little bit of more precautions to infection, because these are the only two problems that will happen in a secondary AI, which is also minimal. Okay. So like it said, negligible risk, no supplementation required. Okay, mild risk category like few simple extractions, biopsy, minor periodontal surgery. The glucocorticoid target is about 25 milligram of hydrocortisone equivalent, which is the same as the table that we saw, 25 mg hydrocort or 5 mg prednisolone on the day of surgery. This is usually what the patient is taking. So depending on the question that is asked to you, you have to answer. And if it is a moderate to major risk category, that is multiple extractions, one full quadrant periodontal surgery, extraction of bony impactions, osseous surgery, cancer surgery, any major surgeries, in that case you have to give the same glucocorticoid target which we give in any normal patient also. Okay, 50 to 100 milligram per day of hydrocortisone equivalent at the day of surgery, and for at least 1 or 2 post-operative days also, because of the pain of surgery you will go. So there is nothing different that you will do in a patient. You will give him his daily dose of steroid plus this regimen which we follow in all the patients. Okay, now we come to some Australian and New Zealand recommendations, some recommendations from other universities also. So they are saying that if the steroid dose is small, 7.5 milligram prednisolone, okay, because इन्हीं tables में से सारे questions आएंगे. 7.5 mg prednisolone, which is 1.5 times the normal body production of cortisol. Okay, for GA or LA, both you don't need any supplementation. Okay, same thing is said by University of Otago. If you are taking more than 7.5 mg prednisolone, again, just for LA procedures, you can double it on the day of surgery. Okay, if it's a major surgery, you can double it on the day of surgery if you are taking a high dose steroid and if it is a major surgery. Okay, and of course, if it is a GA surgery, you will do the same thing, 100 mg hydrocortisol equivalent and maintain the usual dose. So those usual doses not changed. Okay, yes, it does recommend that double the dose just on the day of surgery so that the additional stress can be tackled. Okay, basic recommendation is you don't have to change the daily therapeutic dose, but some university says that कोई नुकसान नहीं है अगर आप एक double dose दे देते हो तो. Okay, and again Australian also says is just double the dose on the day of surgery, and for GA the same protocol. If the patient is taking very high dose of prednisolone, again it says that for minor surgical procedures no supplementation is required. Okay, and appropriate major surgery ke andar whatever we are doing we have to do. Alright, so this is the protocol that we have to follow. I will do a conclusion for all of you so you understand. Now what if the crisis happens? What if there is a crisis? What is crisis? Crisis means deficiency of cortisol. What if there is actually a deficiency of cortisol and you are not able to take care of that cortisol deficiency because of primary AI or because you've taken the patient to GA without giving additional steroids? What will happen is, like we said, there will be hypotension, bradycardia, hypoglycemia, and other electrolyte disturbances. So what we will do here is, we will basically manage the symptoms. What we will do is, we will give IV steroids, hydrocort, we will give IV glucose, okay, we will give IV fluids and electrolytes. Whatever is the problem, whatever is the crisis, first of all, you will give some IV quick steroids, immediately acting steroids, maybe an intermediate acting like hydrocortisone, and manage the situation. Okay, honestly speaking, this crisis during dental surgery is very rare. Doesn't happen. So don't worry. Just don't miss the daily dose. Let the patient take his daily dose. Okay? This will not happen. How will you prevent this? Yes. If there is a very 0.1% chance, you can prevent it. How will you prevent it? Stress reduction. Talk to the patient. Give him less stress, less psychological stress. Prevent hypoglycemia. Okay. Make sure that the patient has eaten well. If he's a diabetic, he should not be on insulin and diabetic and not taken his meal. So prevent hypoglycemia. Okay. Give good painkillers. Analgesia should be good because pain also increases the need for cortisol. Pain is also a very big stressor. So reduce the stresses, reduce the stress, prevent hypoglycemia, give good analgesia, give good local anesthesia, and usually you will not need any extra steroids in a patient on exogenous steroids. All right. So what is the conclusion here? Okay, let's discuss 5 questions that have come previously in the exam with answers, and then we will conclude that is subset. We have seen Indian protocols, we have seen universities, different university protocols, we have seen the protocols depending on the type of surgery. Now let us see the questions that are asked in the exam. A patient was taking 20 mg cortisone. Okay, now what is 20 mg cortisone? Going back to the equivalence chart, it is a very mild dose. It is the same dose that is produced in the body daily. Okay, he is taking 20 mg cortisone continuously from the last 4 years. Now he underwent extraction of his tooth and he developed symptoms of breathlessness, syncope, pale face. Okay, what is this due to? This is due to overdose of steroids? No, this can't happen. Hyperglycemia? No, it has to be hypo. Unfavorable environment, condition, anxiety? Yes, that can happen. This is very well possible. Because acute adrenal insufficiency, yes, that is also possible. So you have to rule this out. But this is very, 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 very rare. It is very, very rare to have an acute adrenal insufficiency in a patient with 20 mg cortisone. Okay? But you have to rule it out. You have to always see whether it is, just an unfavorable anxiety which is causing syncope. So depending on the language of the question, you have to answer. So these are certain controversial questions. This can very well be a syncope, or this can be an acute adrenal insufficiency. If I talk theoretically, okay, theoretically अगर breathlessness आ रहा है, because syncope में usually unconsciousness होता है, breathlessness नहीं होता है. Pale face definitely हो सकता है syncope में. So this can happen in syncope, but breathlessness, टैकीकार्डिया, टैकीपनिया, हाइपोटेंशन, ये सारी चीज़ें यूजुअली सिंकपी में नहीं होती हैं. सब कुछ डाउन जाता है. सो दिस इज अ कॉन्ट्रोवर्शियल क्वेश्चन. ऐसे क्वेश्चंस में घर से डिसाइड करके जाओ कि ये क्वेश्चन अगर आया, सो आई एम गोइंग टू मार्क ए और आई एम गोइंग टू मार्क डी. नाउ आई हैव टोल्ड यू बोथ द थिंग्स. व्हाट द प्रॉब्लम इज, दीज क्वेश्चंस आर रिकॉल क्वेश्चंस. बच्चे को जो याद आया, बच्चे ने ऑथर को बताया, ऑथर ने वही क्वेश्चन लिख दिया और बुक में डाल दिया. So these are poor recalls. The student doesn't remember whether the dose of steroid was this, whether the dosing was given, whether only these were the symptoms or there were some more symptoms. Okay, I have just copied this question from one of your books and I have tried to explain what is the problem in solving these questions. Now you know the concept. It can either be A or it can be D. In exam, definitely there will be a better framing of the question, and depending on that you have to mark either A or D. It is much more common to have a syncope attack due to unfavorable environmental conditions rather than an acute adrenal insufficiency. It is very, very, very rare in a dental chair. Okay, but if the examiner is wanting to ask you about AI, he will put more symptoms like hypertension, excessive sweating, does not recover on position changes, because syncope patient will recover as soon as your position is changed. If the patient is not recovering after the position is changed, yes, then you will think of acute adrenal insufficiency. So this is how you have to rule out the options in exam. Second question. A patient who is on a regimen of steroid therapy has the need for extraction of clinically infected teeth. Requires a pre-medication with. So यहाँ पर regimen कितना है, क्या है, कुछ mention नहीं है. ठीक है? Just he is on steroid therapy. Now he has an infection stressor. Already the stressor is present in the body. Your extraction will be a stressor, but the infection is already a stressor which is there in the body. Right? So what will you pre-medicate the patient with? Atropine, an anticholinergic? No, I don't think we need an anticholinergic here. Antihypertensives to combat the tendency towards shock? No. Usually in steroid crisis, there is hypotension. So you will not give antihypertensives. Antihistaminics to prevent allergy? There is no role of allergy here. Antibiotics? Yes, definitely, because we know that steroids will reduce immunity. So pre-medicate, give the patient a usual dose of a steroid, normal dose of steroid. Normal means whatever the patient is already taking. Let him take that. Plus, just before your procedure, give him some little bit of extra antibiotics. So that a baseline antibiotics is there in his body when you are doing the procedure. And the chances of infection due to reduced immunity are slightly lower. So correct answer here will be antibiotics. If there would have been option of additional steroid with antibiotics, that would be a better answer because it is an infected tooth. It must be paining. That is why the patient has come to the doctor, right? So if the option is antibiotic and a little bit of extra steroid, yes, you can go for that answer. Okay. A patient who is on long-term steroid therapy, what precaution is to be taken prior to tooth extraction? Stop the steroid before extraction? Obviously not. You will be inviting a steroid crisis. Additional steroids to be given? Yes, this can be considered. More antibiotic cover? Yes, this can be considered. Continue steroid as it is? Yes, it can also be considered based on what is the dose of steroid, what is the status of extraction. So these are vaguely presented questions. If the patient's dose of steroid is low dose, if the extraction is of 1 or 2 or 3 periodontally mobile teeth, don't have to do anything. Just give an antibiotic cover because of reduced immunity. Nothing else to be given. Okay, so here 3 options are correct. I am purposefully discussing these controversial questions because multiple options are correct because these are recall questions. Students have recalled these questions और जो भी उन्होंने पढ़ा है वो सब एग्जाम में खिचड़ी हो जाता है and they come up कि ये भी था, ये भी था, ये भी था. So understand the concept and depending on the language of the question, mark. Okay, this should not be done. Okay, additional steroids can be given, same steroid can be continued, and antibiotic cover should be there. So this definitely should be there. Whether you give additional steroids or continue with the same dose, this should definitely be there because steroid घटे या बढ़े, long term steroid में immunity जरूर घटती है. So definitely you have to give antibiotic. So that is the best answer. And if this is the same question which is asked in the exam, I will go for C. Okay. Next question. The dose of corticosteroid to be administered to the patient who takes 60 mg of hydrocortisone daily on the day before extraction should be. Now, यहाँ पर 2 चीजें हैं. 60 mg hydrocortisone. How much is it equivalent to the normal body production? Let's go back to the table and see the equivalent dose. So 20 mg is normal. The patient is taking 60 mg, which is 3 times of normal. Right? He's taking 3 times of normal. So definitely his body, his HPA axis is suppressed. So he will need more steroids. Right? So how much more will he need? Read the question properly. The dose of corticosteroid to be administered to a patient who takes 60 mg hydrocortisone daily on the day before extraction. Why will you supplement steroid before extraction? You have to give the steroid, additional steroid, yes, because he's taking a very high dose steroid, 3 times the normal body secretion. He should be given, he should be doubled, but not before the day of extraction. On the day of extraction. So 120 mg should be given. You can double the steroid on the day of surgery. On the day. That means if you are doing a surgery at 10 a.m. in the morning, give him an additional steroid at 9 a.m. Not 1 day before extraction. So this is how word play. This is word play. This is how the examiner is going to play with your minds. Okay, बहुत अच्छे से steroid आ गया. चलो मैं English का एक वो डाल देता हूँ. A twister I will put. So here the question is, how much will you give before? No, before is not required. At the time of surgery and after surgery is required. Because at the time of surgery, there is stress of surgery. There is stress because of anxiety, fear. And after surgery, there is stress because of pain. So during and after surgery, or just before and after surgery, you have to give additional steroids because this patient is taking very high dose of steroid. 30 mg is 3 times. Alright. So here, because before is asked, you will give the same dose as 60 mg, and that is your answer. One day before, 60 mg. On the day of surgery, 120 mg, which you will taper down slowly, slowly. Okay, on the day of surgery, you've given 120. Next day, maybe you will give 100. Then you will give 80. And then you will come to the daily dose of 60. You will taper the steroids slowly, slowly, depending on the magnitude of surgery. All right. And one last question that we will see here. A patient is on 8 mg prednisolone for an autoimmune disease since the last 3 years. Now, HPA suppression hota kab hai? HPA suppression happens in around 3 weeks. If you are taking, say, a large dose of steroid or a divided dose of steroids, it takes 3 weeks for a reversible HPA axis suppression. Okay. She needs to undergo a transalveolar extraction of the mandibular third molar. Now, this is a little kind of a moderate surgery. Alright, how will you proceed in this case? So 8 mg prednisolone. Going back to the table, what is the meaning of 8 mg prednisolone? Normal prednisolone in the body equivalent is 5 mg. So she's taking 8 mg, which is around, say, 1.5 times of the normal. Okay, so she's taking more than normal, and she's undergoing a moderate surgery, which is a third molar surgical removal. Okay, so I might want to give a little bit of steroids during surgery so that the patient is comfortable. Okay, so what will I give? Pre-medicate with 2 gram amoxicillin 1 hour before surgery. Yes, this is right, but this does not include the extra steroid that you need to give. Check bleeding on probing. Pre-medicate with antihypertensives like a CCB or diuretics. No, there is no role of antihypertensive or no role of bleeding on probing. So this is wrong. Proceed normally but keep atropine and adrenaline ready in the crash cart. मतलब आप चाह रहे हो कि emergency हो और emergency हो और आप crash cart से emergency drugs use करो. This is a very bad approach. Your approach should be prevention of emergency, not be ready for the emergency. Last option is pre-medicate with amoxicillin and 15 mg prednisolone 1 hour before surgery. So this is the ideal option. Pre-medicate with an antibiotic because the long-term steroid that she is taking is going to give her immunosuppression. Uske liye pre-medicate with antibiotic, and it's a relatively high, 1.5 times the normal dose of steroid. So give her a little bit of prednisolone extra 1 hour before surgery. So this is the best option among all the options. Alright. If the language of this same question would have been 5 mg prednisolone or 4 mg prednisolone and grade 3 mobile anterior teeth, maybe I will not supplement with extra steroid. I will just go with option 1. But since it is 8 mg prednisolone, which is a slightly higher dose, long-term steroid and a bigger surgery like a transalveolar extraction, which is a surgical extraction, I will definitely want to give her a little bit of steroid 1 hour before surgery. Alright. So with this, we end. I hope the concepts are clear to you. In the comment box, do tell me whether you have understood. I am purposely using English because South वाले बच्चे फिर मुझे मारेंगे कि मैम आपने हिंदी में क्यों पढ़ा दिया इतना important topic. So tell me your feedbacks, whether you have understood. If there are any doubts, please tell me your doubts also. In a conclusion, but do leave your comments, right? In a conclusion, I will say, whenever there is a question on steroids, first you see whether it is primary adrenal insufficiency or secondary adrenal insufficiency. Most probably your question will be on secondary AI, that is a patient on exogenous steroids. Okay, because that is what we see much more commonly. Second, you have to see what is the dose of steroids being taken. Dose, and if possible the regimen, that is morning dose hai ya divided dose hai. Okay, based on that you will decide whether the dose is normal body dose or more dose. That chart will tell you. Okay, the chart which is the equivalent chart. So you have to remember the equivalence chart here, the glucocorticoid equivalence chart. Third, you have to see the magnitude of surgery. What is the magnitude of surgery? Whether it is a minor surgery, whether it's a moderate surgery, or whether it is a major surgery under GA. Okay, so for minor surgery, you can avoid steroids. For moderate and major surgery, you will supplement steroids. Okay, how much you will supplement? If it is a moderate surgery, just double the dose before surgery. or give a little extra dose. If it is a major surgery, then use the full protocol, full GA protocol of steroids. Okay, that is 100 to 150 mg hydrocortisone during the surgery, and post operatively also you give a little for the first 2 days and then taper it down. Okay, so the full major GA surgery protocol you have to follow in normal patient also, in AI patient also. All right, so this is the conclusion. I hope it was useful to you. Thank you so much.